Yes, hello, good morning or good evening. I'm Mariette, and yes, I'm in the endoscope for quite some years now. Most important is the decontamination of our flexible endoscopes. Why? Because they are very complicated. They have long, thin channels. We cannot inspect them. We have to brush some of them, not all of them, and then we have to dry them. We don't know exactly when they are really clean or when they are really dry. And finally, that is our key. We have to make sure it is possible, it is done. The decontamination of the endoscopes has various steps, and you see at my slide, teaching, in fact, is to the staff of the staff is the most important one. The one who is cleaning them has to know what they have to do, what they may do, how not to break the endoscope as well, and especially what uh, for me is very important, we have to give them time. The doctor cannot rush you, they cannot shorten the procedure, it has to have a certain time limit, and you need the time to do it correctly. Second is a quality system. Of course, we do need protocols. We do updating of protocols, and we have to repeat that all 6 months, every time, every change when something change, or every 2 years at latest. Supervision of the daily routine of how we decontaminate would be a very important step. Everybody has a right to be checked on. Supervision is not something that is difficult to handle, but you have the right to have a supervision. You have the right to know whether you're doing a good job or not. So manual pre-cleaning, as Jill and Bassa told us, the IFU is extended to sometimes more than 100 pages, and we can't know everything anyway at a hospital or at the endoscope area. We have a certain possibility to work. We cannot work 100 pages each time. So manual pre-cleaning has to be in a standardized way, and we have to do always the same, at the same movements, same steps, one after another. We have to repeat it, and our colleague has to tell us, oh, by the way, you forgot now to brush, or by the way, there is another thing on it, there is a little dirt. We have to check on each other. Mechanical cleaning and disinfection is, as far as I'm concerned, absolutely necessary after the manual pre-cleaning. And also there, the manual pre-cleaning has to die immediately after use. Then we have a little time, please, a little, 20 minutes, 30 minutes. And then it has to go into the mechanical cleaning area, how we call it. Drying and storage is the next thing. Without that, endoscope is dry. We only clean, we only disinfect, we do not sterilize. There are still some microorganisms back in this endoscope, if we do like it or not. We have to dry it. And dry doesn't mean 1 drip, 2 drips, 3 drips. 1 drip is wet. Dry is no drips. And we have to take our time as well. That's why I think it has to be a mechanical drying as well. Then we have the culturing of the microendoscopes that you have to do periodically, once a year, twice a year. I don't know. We will continue to discuss it. Auditing, a very important step. Auditing once a year, twice a year, how we continue, how we validate our equipment, how you make sure that we are doing always the same thing at the right time with the right endoscope. And finally, but not last, the management of incidents. We all have incidents. We don't like to speak about it, but we know from each other that we do have them. We have to have a plan. We have to do it. Teaching of the staff. Education about microorganisms, yeah, it's fine that the staff knows what it is. Education about cleaning, disinfection. What do we do with cleaning? What do we do with disinfection? We can't do miracles. We only clean with water and soap, and we disinfect with a disinfectant, sterilant. Knowledge about the construction of the scope, the different channel, what connection are used, are they disposable, are they reusable, what can we do? We have to plan all these steps of manual cleaning, and please always at the right order. And we have to register this decontamination. We have to know whether each step has to be done, is done. Next slide, please. The quality system, we have to develop our protocols. We have to write it down. We have to have a meaning of communication. How can we teach the stuff how to do it? But how can we know it ourselves? What channel has to be brushed? What channel has to be flushed? The leak test, of course. Manual pre-cleaning directly after use, as soon as possible, after 5 minutes, after 20 minutes, but certainly not after 2 hours. If that happens again, we need a protocol how to deal with it. Extensive soaking, it has to be in a protocol. Mechanical cleaning, disinfection, drying, storage, and then last but not least, again, the reparation. Scopes are very difficult devices, they will break down. Supervising of the daily routine, peer review, as I told you, we have to know the fixed order of the different steps so we can help each other, and auditing at least once a year. Mechanical cleaning and disinfection, process release, whether the machine did the right thing, validation, measuring once a year by knowing the temperature, knowing the concentration, knowing the time, as well from the mechanical cleaning, as well as the drying cabinet has to be validated. Next one, please. Periodically culture of the endoscopes. Quite a difficult theme to address because we do not like it. What are we doing if it is positive? We have to define it. We have to know it in advance. What we will do with this culture with the dirty endoscope. It is dirty. We cannot change it. We have to discuss the method of cultivation with the laboratory where we send this fluid. We have to know what to do. Again, that is something Jill certainly knows everything about. It's difficult for the staff at the endoscopic service, but the infection prevention knows how to do, and they will manage it to do a good plan and we do cultivate the most difficult endoscope twice a year, only as control for our work. Do we do it right? Do we miss some steps? And if the most difficult endoscopes are clean, I hope that the most easy one are as well. Last, again, but not least, auditing of the yearly validation. Auditing is when your, next slide, please. Auditing, I put on the diagram here our system, how we do audit. I'm doing that myself with one of our staffs, and we follow all the steps what we have to do. First, policies and cleaning. Do we have it in order? Then certainly at 1.4 you see all accessories used in sterile body cavities are sterilized. Our rules ask that everything has to be sterilized, disinfected or sterile at the highest way possible to achieve. So if it can be sterilized, it has to be sterilized. Except when I think the valve, we do not sterilize the endoscopes. Why would we sterilize the valves? I think it's not really important. I accept it. The document there are documented is in written. Not possible for me. You can't have documents in written somewhere in the service where some notes are there. All the documents has to be in the quality system and has to be ordered in the same way. All accessories are clean and possibly disinfected in the department. A list has to be present which medical devices are there and which has to be treated in which way. When you have then some points where it's no, you have to give priority to when repairs are needed. If it's checked whether what priority to give you, in what order they have to better things, to adapt things. Next one, please. Manual handling of flexible endoscopes. We in Holland, in the Netherlands, we accept that an endoscope which is not dried can be handled, can be used 4 hours after mechanical disinfection. But then it cannot be kept longer as these 4 hours. After these 4 hours, it has to be returned and it has to be disinfected again. No problem. We put an hour on it. For our services, no problem. Manual pre-cleaning of endoscopes, and there 3.2, you see, the protocol is present and easily acceptable. And when you are then auditing and you ask staff, where is the protocol? Oh, yes, she didn't, no, she didn't, Sorry, the protocol has to be there, has to be present, and she has to know it. And in fact, nowadays, she has to sign that she saw it. Priority immediately, please. Has to be done. Only water, no soap solution in the treatment room. That is something that also for me in the treatment room where the patients are, I don't want to have any soap because I don't want to have a suction of soap into the patient. Next diagram, please. Transport, it has to be closed, no problem. It has to be dry when it's going to the patient, and it has to be closed when it's coming from the patient to the disinfection room. I think for us at this moment, we do not work on more than 3 locations. It can be handled. Next one. Drying storage. Drying storage has to be cleaned every day. Once you take an endoscope out, you have to clean and to disinfect the storage cabinet. This drying cabinet, by the way, we use a drying cabinet as well as storage cabinet. That it's not really necessary. You can also use the drying as a drying cabinet to dry and then put it into closed boxes. It's fine with me as well. And you can keep it for 1 month. After 1 month, the scope has to be mechanically disinfected again before use. Next one, data registration. You have to register all the steps that you are doing and who is doing it, which patient, which doctor. So a recall has to be possible when something, our superbugs appears or something else can always appear. There are a lot of people working and mistakes can be made. So be aware and realize it. Hygiene, aseptic working is observed. You have to control, to check on each other. Staff, next slide, please. Staff expertise. Everybody has to follow some formation, some education in between. At least 1 formation each 2 years. Otherwise, they are not able anymore to work with the endoscopes. And it has to be written, and it has to be in the personal dossier, how do you call it, in personal papers, that you have done it. You have to have a certificate. An audit, again, here also priority, and you have to follow, the department has to follow up this priority. Otherwise, also, next slide, please. Recommendation. If they can't do it, they have to stop working. I stopped one worker because they didn't have a certificate. So sorry, no work anymore. You can do the cleaning or you can help each other, but not anymore any endoscopes. You're doing that once, and people learn to follow up protocol. Then for last, sorry, Natalie, I will finish soon. That is an incident. There are incidents. We all have incidents. Specialists assessing the problem, danger for the patient. Can we do a recall only if the registration has to be done? Information of the authorities. You have to inform the Minister of Health. Maybe you have to decide it. Prevention of future similar incidents is for me almost the most important things. How to prevent not to make mistakes. We all do, but at less as possible. That is my presentation for here. Thank you for your attention, and please tell us when we have more questions.